Okay, so I suppose we can start now. Can I get Dr. Razif? Shall we start?
Yes, Dr. Geeta.
Okay, all right. So I suppose the FB Live is working now. Um, right, so we have 18 now in this Zoom platform as well. So we can start while waiting for the others to join. Um, so I just want to give a very simple opening remarks to this Obesity Week Malaysia 2025. Good afternoon and salam Ramadan to everyone joining us on Zoom and Facebook Live platform. We have several joining from the Facebook Live as well. So thank you so much for spending your afternoon today with us, joining and to hear some of the talks from our good, very esteemed speakers talk today. I just want to welcome all of you to this Obesity Week Malaysia 2025, a meaningful platform where we all experts, policymakers, researchers, and public come together to tackle one of our biggest health challenges at this day, obesity. And this is our fourth year conducting Obesity Week Malaysia in conjunction with World Obesity Day, and it's definitely a milestone that we all are very proud of. This year's theme, Changing System, Healthier Life, highlights that obesity is not only a personal issue, but a complex problem that needs action from all parties, society. So throughout this week, we'll discuss about science. We'll also discuss about policies and creative solutions to help Malaysians live healthier life. A special thank you to all to our sponsors, Inoa Pharmaceuticals and Angsana Health, for your support and shared commitments to building a healthier Malaysia. To our speakers, we have several speakers today and also on Wednesday as well as on Saturday this week. Thank you for being part of this journey. Your knowledge, idea, and experience will drive important conversation and practical steps to improve obesity prevention in our country. I would like also to thank my fellow council members, most of them are here, I suppose, for your hard work and dedication in making this event possible. Finally, I also encourage all of you to actively participate in our webinars as well as other activities that we have for you. Share your views and connect with our others as well. Together, we can move from the blaming individuals to fixing the system and create a healthier future for all Malaysians. With that, Obesity Week Malaysia is now officially open. Let's have a productive and inspiring week ahead. Thank you. So we will have today, as I said, today is the first webinar, part of this Obesity Week Malaysia 2025. The theme for today's webinar is innovative approaches to combat obesity. As I said in my opening remarks just now, we need to understand the latest and innovative approaches to combat obesity. And we have several speakers for this webinar today. First speaker is Professor Meng. Yeah, Professor Lee is here. He's from Sydney. I will introduce Professor Lee in a while. Second speaker, Professor Dr. Rohana Abdul Ghani from UiTM. Third, Dr. Ginsky Chan from Angsana Health. And the last speaker for today is Dr. Claudia Lopes, who will be speaking on behalf of UNU. Yeah. So let me introduce our first speaker, Professor Lee. Yeah. Professor Lee, I hope you don't mind calling you Professor Lee. All right. Professor Lee is a director, Population Health Research Evaluation Hub from Sydney Local Health District. He'll be speaking on a title on early prevention of childhood obesity, the journey of healthy beginnings trials in Australia. Let me introduce him. Professor Lee is a renowned expert in medicine, social science, and public health, with over 200 peer-reviewed publications in prestigious journals like BMJ and JAMA. He currently serving as a director of Population Health Research and Evaluation Hub at Sydney Local Health District, focusing on health promotion, research, and evaluation. Has worked and also still working on research interests include childhood obesity, physical activity, active transport, sexual health, and tobacco control. He has received Better Health, Good Health Care Baxter Award in 2000 and the NSW Health Awards Preventive Health category in 2014. Yeah, he's principal investigator of the I know it is very competitive research in Australia with NHMRC funded health beginnings trial, the groundbreaking study aimed at reducing child obesity in disadvantaged areas in Sydney. And so this program, our research is first of its kind, was published in 2012. If you're interested, please have a look of these publications. And it also leads the development of additional health beginnings programs in Sydney, I suppose. With that, Professor Lee, the screen is yours.
Thank you, colleagues, and thank you, Chair, for your introduction. I'm very much delighted to be here and talk about my passion in early childhood obesity prevention. May I just share my screen first? Hopefully that you can see my screen.
Yes, it's there. Yes.
Okay, that's fantastic. Again, thank you all for your participation and for your interest in early childhood obesity prevention. What I'm going to talk about is our journey of healthy beginning trial conduct in Australia. That's over past almost close to 20 years for that work. So what I'm going to talk about in my presentation is probably just very briefly mention about the issue of childhood obesity, and then talk about framework for preventing childhood obesity, and also early risk factor for childhood obesity. And then I'm talk about the healthy beginning trial and how healthy beginning trial being translated into other form of healthy beginning. And also I make some remarks in conclusion. Okay, obviously, everyone knows probably the issue of childhood obesity. And globally, close to about 400 million children and adolescents aged 5 and 19 years were overweight in 2022. That's probably after the pandemic. And in Australia, in particularly in early childhood, I'm talking about 1 in 5 Australian children by the age of 5 is affected by overweight and obesity. So probably you all know there's a very strong link between obesity in early childhood and adolescent and adulthood. Obviously, there's the impact of the COVID-19 pandemic on the childhood obesity. And also evidence suggests there's a greater link regarding the early onset of childhood obesity and related to high blood pressure, depression, and also heart disease, diabetes. There's lots of other issues, health issues related to early childhood obesity. Obviously, there's an economic case for early intervention. So I list these slides here is regarding invest in early childhood year $1 investment in early childhood years a $13 return. That's the economic modeling. But this talk about broad health issue in early childhood, not specifically for childhood obesity. Obviously, there's a lot of people done economic modeling in this space as well for childhood obesity. So when we talk about framework for preventing childhood obesity, you all know the socio-economic model framework. We look into childhood obesity and the family influence and also society influence and also government structure as well. So because with this kind of a socio-economic model in mind, in 2002, that's almost 20 years ago, in Australia, New South Wales Parliament House, in fact, hosting an event for childhood obesity summit. At that time, they gathering all the staff specialists working in early childhood, family and community, and school education, health, and also media's transport planning. So they all coming together to talk about how can we combating childhood obesity. So that's kind of using that kind of framework to informing our prevention guideline. So you also think about in the early years prevention, we also look into this kind of lifespan prevention, looking into pregnancy, postpartum, and later life. Obviously, that's the issue we need to address during the pregnancy, after giving birth, and how can we this look into later life prevention as well. But when we look in the early prevention, so I using this kind of this framework, this kind of key issue related to early risk related to childhood obesity prevention. In particular, when we talk about conception, at that time, maternal and parental obesity is important. During the pregnancy, that's gestational weight gain, maternal smoking, and maternal diet and the physical activity all influence the birth weight. So birth weight become another important issue. And also, after giving birth, the early infant feeding practices, that's another key issue related to childhood obesity, particularly when we talk about breastfeeding, rapid infant weight gain in the first year, and also sleeping is another important factor, and also feeding behaviors. So another probably soft evidence, I'm talking about soft evidence because probably the evidence is not that strong in terms of timing of introductory solids, food for rewards, bottle feeding. There's other parenting style issue as well. All those issues contribute to the early risk of factor for childhood obesity. So we know that from health perspective, we know that childhood obesity is a huge issue. But when we talk to the community, when we talk to mother during pregnancy, they say it's not an issue at the moment, because that study we conduct with those who was pregnant during in the late pregnancy study, we conduct a focus group with them. What we found is mothers don't care about the issue of childhood obesity, but they more care about their issue related to their child giving birth and childhood health in general. So can we address that issue? So we're using a kind of a health promotion series and health belief model that's try to influence on their mother's perception regarding severity of the health issue and the perception of health benefit. And through this kind of changes their perception about health issue to enhance their health motivation and take action on childhood obesity prevention. So that's why we started a journey on health beginning. So that journey started 2007, and we're still working on health beginning as well. Currently, we've got a number of projects going on. Now I'm share with you some of the project related to the health beginning. So in 2007, we published a study protocol called Healthy Beginning Trial. What is the Healthy Beginning Trial? It's using multiple home visits to prevent childhood obesity in a disadvantaged population through a home visiting model. So the key here is to influence on mothers' behavior in terms of their feeding behavior, improve their awareness about childhood obesity. The key intervention message is about breast is best, no solid for me until 6 months. only water in my cup. That's the influence on their feeding behavior, and no TV and promoting fruit and vegetable. So that work is through a home visiting program. What have we done? We conduct a randomized control trial. That slides show you how we conduct it. We recruit mother from their late pregnancy and then randomize into two groups. One group is usual care, another group receive multiple home visits. In total, we provide 8 home visits through their first 2 years of life. So the key information or key message for each home visit, that's probably I listed in the table because everything's already published. You can find the paper from the publications. So what we try to emphasize through each home visit, so looking into breastfeeding, introductory solids, bottle feeding, and other parent-child interaction and family support. All those issues addressed through a home visiting program. So what we found from this kind of intervention is we found from this kind of through the home visiting intervention, we can improve infant feeding behavior and tummy time. Not only that, most important finding is through a breastfeeding promotion, because we know breastfeeding is very hard behavior to influence on for mothers. So through this kind of intervention, we can significantly improve breastfeeding rates. Another key finding is we published in BMJ in 2012 is regarding BMI difference between the intervention group and the control group. So what we found is through that kind of stage home visiting program, we can influence on BMI by 0.29 at age 2. So that with this kind of finding, what that means, often people ask, so what does that mean by you reduce the mean BMI? What I try to demonstrate here is we try to push through the intervention, you try to push the curve, the BMI curve towards left. What does that mean? Potentially, you can translate it to, at the population level, almost a 3% reduction in childhood obesity. That's a huge and significant findings. So with this kind of significant findings, BMJ issue a press release titled "Healthy Eating Advice for New Mom Can Help Cut Childhood Obesity." So that's the kind of an early intervention through home visiting. We can make difference. But what about the cost? Probably not sure everyone knows in terms of home visiting program. So the cost, in particular with staff cost involved in home visiting, is huge in Australia. So we did a kind of economic evaluation, looking into what sort of cost and the cost benefit. What we find is kind of moderate cost effectively in terms of using home visiting to prevent childhood obesity by age 2. Another key findings from our trial is we did another 3 years follow-up with healthy beginning. You remember the initial stage, we only look into age 2 in terms of their BMI difference between the intervention and the control group. What do we think about another 3 years follow-up? Say, without the further intervention, what happened without the further intervention? So what we found is that without the further intervention, if no intervention after age 2, and then by age 5, all this early intervention effect diminish over time. By age 5, we can't see any kind of difference. So what that means from our research, what we found is we need to offer a continuity support. We need to find out low cost, and can be sustainable program. That's why we think we need to find out what sort of program can be integrated into existing programs. That's we try to build healthy beginning intervention message into our existing health service. We cannot rely on this single program. We need this program to be sustainable in the longer term. So we need to find something more low cost and with broader population reach in terms of the program. That's why over the past 10 years, we look into how can we translate this kind of healthy beginning trial early funding into various programs. So we conduct a number of programs built on our healthy beginning and early fundings. So just for your information, now healthy beginning model is listed on U.S. Department of Health and Human Service as a recommended early effective model for promoting infant feeding practice, childhood obesity prevention. And another research in how can we using new technology, probably you all know, an app, with smartphone development, app is very popular now. So we developed our called Healthy Beginning app to promote healthy beginning messages through this kind of healthy beginning app. So instead of doing a scheduled home visiting program, we ask a mother to using this healthy beginning app. This app initiative also being adopted by our Chinese colleagues in China, in Fudan University. Another study we conduct over the past 10 years is called chat study. It's looking to how can we communicate healthy beginning message advice by telephone. So instead of doing home visiting, we're using telephone or text message to promote healthy beginning messages. So what the study looks like that. You remember the healthy beginning trial, the early stage randomized trial intervention and the control intervention receive a multiple home visits. So for this child study, so we develop a 3-arm trial. So one arm obviously is the kind of control arm. The other 2 arm is the so-called telephone support arm, and another called SMS arm. So what we try to find out is whether healthy beginning intervention can replicate through telephone support and SMS. So what we done is for telephone support and SMS. So basically, we develop a scheduled intervention booklet. So all the information by all the booklet we develop with all those staged intervention. We mail to them, and then we follow by either telephone support. So those telephone support by our early childhood nurse to discuss the health issue, in particularly the childhood obesity. Or we send out text message 2 times a week for 4 weeks in each stage. In total, we provided 9 staged and kind of intervention for the first 2 years of life. So what we found in the main finding at 6 months and 12 months through that kind of a text message or telephone support, we found telephone support or text message intervention were effective in particular reducing screen time and using bottle at bedtime. And we've also found that telephone support was also more effective in terms of promoting the proper timing of introductory solids and early start timing time at cup feeding. Another finding is at 2 years. So that's 2 years. What we find is that both interventions still effective in reducing bottle use at the bedtime. but we found no BMI effect from the text message and telephone support intervention. So you remember the earlier home visiting program by the age 2, we see the difference in BMI, but not showing in telephone or SMS. We also did an economic evaluation for that model, for the chat model. What we found, SMS intervention was most cost effective for the outcome. But remember the cost effective, it may not cost effective than the home visit intervention. So home visiting is costly, but it's more cost effective in terms promoting healthy weight and reducing BMI for age 2. So another study we also done, probably just follow on the previous telephone and SMS. You remember we did a telephone support intervention and SMS. What we found is how about we combining these two interventions in one arm? So we exactly did a combined telephone and SMS support in reducing childhood obesity. So that's a 2-arm randomized control trial for age 2 and 3. So what we found by this kind of 12 months of intervention, combining telephone and SMS support for mother at age 2, what we found is the key here is they can improve those dietary and activity intervention. But regarding BMI at age 2, we only found the BMI at age 2 change for those low-income family, but not in the high-income family. So that's the important message from our intervention study. So what we found is this potential we can use in telephone support or plus SMS to reducing childhood obesity and in particular BMI for those low-income families. We also reported this further study, follow-up study between age 2 and 4 years study. So this study is conducted during the pandemic. So what we found is there's lots potential we so-called health benefits through telephone support, because that started during the pandemic. Most face-to-face service has been suspended during the COVID pandemic because telephone support and SMS make a significant roles in promoting child health during the pandemic when the service is being suspended. So the key message I want to promote here is regarding our early intervention. So what we found is obviously home visiting is very effective in terms of promoting child health, in particular infant feeding practice and childhood obesity, reducing childhood obesity. And other model, for example, the app and the SMS telephone support, they produce a small interim effect in terms of promoting infant feeding practice. But it's not showing in the reducing childhood obesity, BMI for general population. The effect, the telephone and SMS only showing significant effect among those low-income families. What are the key lessons from here? So each model, there's a strength and a weakness from them. For example, home visiting, very time-consuming, very, very time-consuming, potential costly. Telephone support, yes, it's effective, but compared to home visiting, it's less effective. But SMS is very convenient in terms of the in terms of communication between the mothers and families. So what we need for early childhood obesity prevention, we need to develop a suite of program. I'm talking about suite program is using different mode of and delivery for meeting the needs of our community. So I'm probably going to stop here. I would like to spend a bit of time to give you a chance to having a bit of discussion on this. I'm going to stop sharing. Yeah. So maybe we can spend a bit of time on question and answer, and we can discuss some issue related to the activity you're doing in your country, and we can have a bit of discussion.
All right, thank you. Thank you, Professor Lee, for your very good and comprehensive talk within this 30 minutes of time given to you. So I appreciate that time limitation. But anyway, Professor Lee, I can open the questions for the audience here. Any question from the audience? We have several in the Zoom platform. Anyone? But while they're thinking a question to ask to you, maybe I can start off. Professor Lee, I just want to ask you your opinion about, we still probably need some of the personal touch, human touch, because I can see the home visitation seems to be working, but, with the telephone and the SMS probably not so effective in this case. So we may need the human touch, the human influence on influencing these changes. What do you think? How can we make it better in terms of, we have AI these days that maybe we can include the human touch into the AI aspect. Maybe you have some opinions on that.
Yes, that's actually the things I haven't mentioned regarding. We are currently developing a healthy beginning website. In the website, we try to build a chat box so mother can talk to the chat box, and then if they encounter any issue, the chat box can provide immediate response to address their issue. Obviously, that's with kind of new technology. So there's a lot of issue regarding using the new technology, and the feedbacks from the mother through their focus group of our experiences, mothers lack of trust. Because in that kind of online messages, they would more prefer health professional talk to them directly, face to face. That face to face contact is still very important. But probably in our community, there's various people, various needs of the community. So that's why I often think about we should have a kind of consumer focused program. What that means, so the program we should provide option for mother, for family, for them to take it. We should have a suite program. So from home visiting service should be there, and if mother prefer home visiting, or some mother just found a very busy mom, they prefer receive text message, or they prefer using online information or using app. That we should develop a suite program. That's my journey through our healthy beginning. Is we started with the healthy beginning, a home visiting program, and then we transform to other form of delivery, health promotion kind of messages there.
Yeah. That is a very good one. I have one more question here from Professor Tilakawati. She's asking, what is the cost borne by this mode versus the conventional delivery of messages? The telephone and the SMS probably. What is the cost that you're receiving?
Yeah, so the cost, obviously, when we're doing the cost, doing our economic evaluation, so when we calculate the cost for telephone services for support, we cost the nurse, our health nurse, their time preparing for telephone support, obviously their hours will work on this. The telephone support call, each call take about 40 to 1 hour because the mother often they had the opportunity to talk to our nurse, health professional. They're using that opportunity to talk about a range of other issues, not only just our focus on how healthy beginning, they talk about potential lots of other health issues. For example, there's also other social issue as well.
Yeah.
Because they develop that kind of report, they disclose lots of other issues. So the cost telephone still bit high support compared to SMS.
Yeah.
The SMS cost probably we only calculated because in Australia only 20 cents each text message. That's two ways text message. But because at the low cost, but the text message there's a character number minimum character you can allow for each text messages. Sometimes we find the issue regarding the messages just not capture the whole health messages there. So we have to use the abbreviation. And that's another issue regarding text message. It's convenient, instant, as a reminder, as a reinforced health message, it's okay, but just not able to provide opportunity for mother to discuss a health issue with you through text messages.
Right.
That's where we found some limitation.
Right.
Yeah.
I suppose, yes. That probably the limitations with that. I'm just wondering, with regards to the socially disadvantaged group that you mentioned just now, could we know more about these the social demographic of these people? Are they?
Yeah. So in Australia, in particular, uh, childhood obesity more evident in those lower income families. So that's the major issue with obesity prevalence associated with lower income families. So we found there's a great need for those income family to receive a health promotion message in particular. They often relate to their low health literacy. Mother have low literacy in general, so they lack of understanding of health issues, so they need more support. So basically, that's the message from us. And obviously, because they have a higher of childhood obesity rate in among those community, our intervention, we can any kind of intervention showing more effect among those group. For those high income families, they probably more well off, though the high education mother more likely take up all the health message, health dietary behavior, all those issues. So that's why we found that that's the difference. So that's another need for we need to make sure when we doing all the health promotion intervention, we need to consider social economic profile about our community.
I totally agree with you, Professor Lee, that we have to have a tailored intervention according to the income or probably the social demographic background. So that's something that we have to learn from you, Professor Lee, maybe in a different platform. So with that, I would like to thank you for your excellent talk today, and we learned a lot from your from your talk. So thank you so much. We will keep in touch with you because as I said, we need to learn from you. So yeah, thank you, and see you soon. Yeah, another platform.
Thank you for your invitation, and feel free to contact me in future.
Definitely.
Thank you again.
Feel free to stay here until the end.
I will. I stay on. Yep.
All right. Thank you. All right. So thank you so much, Professor Lee, once again. I hope you all had a very good session with him. His talk was really definitely one of the very good one to talk about the early life intervention, especially if it's coming from using latest technology, new approaches, and so on. So that's the first talk. Now let's move on to the second talk. Professor Dr. Rohana Abdul Ghani. I think she's here. Hi, Professor Rohana. Hi.
Hi, Prof. Geeta. How are you?
Good. How are you?
Good.
Thank you so much for accepting our invitation. Let me just introduce Prof. Rohana. Prof. Rohana Abdul Ghani is a senior consultant endocrinologist in Faculty of Medicine, Universiti Teknologi Mara. She'll be talking on advancing obesity care, the role of pharmacotherapy and emerging treatments. So as I said, she's a consultant endocrinologist from UiTM. She has special interest in the various aspects of diabetes and obesity. She's a member of development of various clinical practice guidelines, the CPGs, including gestational diabetes in 2019, management type 2 diabetes mellitus in 2021, and the latest, the CPG in obesity in 2023. We work together in this CPG development. She has represented Malaysia in the new consensus on care and management obesity in South and Southeast Asia, a collaboration with Asia Oceania Association for the Study of Obesity. Also, she's also president of MAIOS, Malaysian Obesity Society, Prof. Rohana. Thank you once again for accepting our invitation, and look forward to your talk. The screen is yours.
Thank you very much, Prof. Geeta. And you really undersell yourself, because we are currently working on many projects in the area of obesity, and I thank you for this opportunity as well. So, yeah, the topic given to me today is advancing obesity care, pharmacotherapy, and emerging treatment. This is my disclaimer that some of this are actually provided by the sponsor, and this is my also my declaration of conflict of interest that I'm involved with the industry very much so. Okay, so to start off with, I know we heard from Prof. Lee about what's happening out there in his center, but also bringing you back to Malaysia. And this is the most recent development in the area of obesity. I'm sure most of you are aware that currently obesity is recognized as one of the chronic non-communicable disease in Malaysia, and has been put together in the same platform as diabetes, hypertension, and hypercholesterolemia, affecting approximately 2.5% of adults above the age of 18 in terms of non-communicable diseases. So this is a big win for us obesity to be recognized as such. And the whole point of when MAIOS, Malaysian Obesity Society, was founded was to get this message across, that obesity demands serious attention to be regarded as chronic disease. And in terms of the increase in prevalence, I'm sure you're also familiar with this, that from 2011, overweight and obesity combination is 44.5%, and most recently is 54.4%, both overweight and obesity. But I would like also to bring your attention to the fact that this is based on the WHO criteria, BMI cutoff point of 27, 25, and 30 kilogram per meter squared, respectively. And when we translate that to the local, our local cutoff point of between 23 to above 23 being overweight and 27.5 is obesity, the prevalence is a lot higher, affecting almost more than 70% of our adult population. As well as that is the trajectory that we are worried about. This is from the World Obesity Federation projection, and this is you can see the steep inclination in terms of the prevalence of our all the different populations, particularly affecting our women and our boys. And we are on track to hit 41%. We are now at 21% of obesity in the country, and we are expected to hit 41% by the year 2035. So these are alarming figures, ladies and gentlemen. So why the need to recognize obesity as a chronic disease? Number one, because everyone else out there is already recognizing it. This is from the American Medical Association 2016, that obesity has been regarded as a complex chronic disease, and therefore to advance treatment and prevention, obesity should be considered a disease state as a serious chronic relapsing disease process of energy regulation. In more recent times, I'm sure some of you may have been introduced to this concept on clinical obesity, which was published in the Lancet Diabetes and Endocrinology Commission early this year. And what it did was to define clinical obesity as a chronic systemic illness characterized by alterations in the functions of tissues, organs, and entire individual, or a combination thereof, due to excess adiposity. And this can lead to severe organ damage, causing life-altering and potentially life-threatening complications as listed here. And this is again to emphasize the fact that obesity is one condition or one disease that affects the whole body. It doesn't spare any part of your body, including your eyes and your conjunctiva and your retina. And the preclinical obesity is also stated as defined as a state of excess adiposity, that's a keyword there, with preserved function of other tissues and organs. And it gave another list of These are examples there. But we already know this, that obesity is a major contributor to disease. And as listed here, you have metabolic, musculoskeletal, cancer, psychological complications. We already know this. And yet we deny it. We deny its right to be considered as a chronic disease. But as well as that, it has also been shown that obesity in the different BMI criteria has implications on life expectancy. As you can see here, those with BMI 30 to 35, the life expectancy is reduced by 2 to 4 years versus those with BMI more than 40 or between 40 to 45. The life expectancy can be reduced to as much as 8 to 10 years. Waist circumference is another indicator, and as you know this, that the Southeast Asia Pacific region have a lower cutoff point versus the 190 among the Caucasians. Ours here, South Asians, is 90 to 80 respectively, and this has been included in our clinical practice guideline. But because in over the recent times, we have been highlighted to the fact that obesity is not just a mismatch between energy and intake and energy expenditure that we have led to believe all these years. We have been taught about it in medical school, and that's what it is. But in more recent times, we blame the environment, that our environment is very obesogenic, but as well as that we have been highlighted to the fact that adipose tissue is an endocrine organ on its own, and therefore that explains the clinical obesity of excess adiposity as being one of the major pathophysiological pathways. But of course, you also know about the pancreas, the gut hormones, and our genetic makeup. As you know, we blame it a lot on family members, and the medication that we give, including our sulfonylurea, insulin, our antipsychotics, etc., etc. More in recent times as well, we have been highlighted or demonstrated or showed that there is more to obesity, that there is a part of our body which is called the brain, which increases the palatability and pleasure centers that really regulates food intake and energy expenditure as well. So just a few slides on the introduction of this hunger versus craving. Have you ever thought of which patient you are dealing with as one sits across you? A patient who tells you that I am hungry all the time, I can't stop eating. That will be the hungry brain. The one that that can tell you that I'm not hungry, actually, doctor. I don't feel like I'm hungry, but I want to eat more. I can't stop myself. Those ones. And those ones, the one who slow burn, the one essentially the postmenopause, etc., as an example, that you've got this phrases that says I inhale food and I just inhale the smell of food and I can put on 1 kilogram. So those are those with a metabolic rate very reduced. And as well as that, there is this huge number of patients who have emotional hunger, which has a hedonic eating behavior characterized by negative mood cravings and reward-seeking behavior. So this is the one that is expressed as comfort eating, that when they're stressed, they eat a lot. So these are the ones. And this has been proven scientifically by this multiple clinical studies that showed you this. On the left-hand side here, as you can see, individuals with obesity have greater reward system activation in response to pictures of high-calorie food compared to healthy weight individuals. So that satiety center is enhanced somehow, somewhat. And in the fat or satiated state, the individuals with obesity still show the reward system activation. It's supposed to be dampened once they have been given the food, but in this case, it's still highlighted. So it means it's still quite active. So these are the areas of intervention, the potential area of intervention. So in terms of obesity management, therefore, there has been more recognition in terms of what is available out there. There are several pharmacological options, and some are listed here on the left. But what I want to emphasize to you on the right-hand side of this slide is the medical cost, which is associated with the weight loss. So as you can see, the higher the percentage of weight loss, as in depicted by the of the purple line, 20% weight loss will result in greater savings compared to those with smaller percentage of weight loss. But as well as that, it has a lot of implications. And as I had alluded to earlier, the different mechanism of this obesity-related or weight gain-related processes has given the opportunity for this different mechanisms. So these are the current pharmacotherapy in the market. So we have some of them and we do not have others. So it's listed here and has its mechanism of action, the different doses, and etc., etc. I'm going to go through them in detail a bit later on. In terms of the algorithm, what are the choice of obesity pharmacotherapy? I just like to highlight this Canadian algorithm that recommends. Those on the left-hand side, diabetes, prediabetes, hypertension, OSA, PCOS, they have more metabolic abnormalities. So the first choice of recommendation is liraglutide, which is GLP-1, followed by naltrexone, bupropion, and finally orlistat. On the other side, if the patient has got craving, they've got underlying psychological issues, they've got smoking issues, because as you know, patients who stop smoking, they put on weight. So these are the first choice will be the naltrexone, bupropion, followed by liraglutide, and followed by that orlistat. And then the algorithm continues on. In terms of our Malaysian CPG, this is the recommendation. The classification, as you know, is slightly different from WHO. So pre-obese or overweight is defined as 23 to 27.5 and 27.4, and obese is 27.5 and above. What I want to highlight to you is the second table, which is the indication for anti-obesity treatment. The indication is consistent with other guidelines, which is BMI of 27 to 29.9 kilogram per meter squared, but they are associated with the other complications as listed here, type 2 diabetes, hypertension, hyperlipidemia, etc. However, if the BMI is more than 30 kilograms per meter squared, the indication is already there for patients to start the pharmacotherapy. So the pharmacotherapy that is listed here is orlistat, combination with amphetamine and topiramate, which we don't have actually in Malaysia, but we use it in single individual tablets. Combination of naltrexone and bupropion that we have, which is Contrave, high-dose liraglutide, which is Saxenda, and high-dose semaglutide, which is going to come to us very soon, I believe so. Anti-obesity treatment, however, should be used with medical supervision and careful monitoring as a I just like bring your attention to the sentences down below here, which is the indication is failed lifestyle and dietary intervention. So I'm underscoring the fact that still the fundamental treatment of obesity is diet and lifestyle changes. So if you have failed that lifestyle dietary intervention, which is defined as modest weight loss, requiring additional weight loss, difficulty to maintain the weight loss, unsuccessful attempts despite your diet and lifestyle, and unable to comply with recommended lifestyle changes due to chronic severe medical conditions. And these are the indications, and as I mentioned here earlier, that comorbidities, with comorbidities, BMI cutoff point of 27, and without comorbidities, BMI of 30. And following that, just of note that responders are defined as 5% weight loss in non-diabetic patients and more than 3% weight loss in diabetic patients should be achieved after 3 months of treatment. Prof. Geeta mentioned this, that I was involved in this obesity in South and Southeast Asia, new consensus on care and management, which was published middle of 2022. And again, basically highlighting the same thing in terms of the indications of pharmacotherapy. So what are the pharmacotherapies we were talking about? The newer ones, Contrave is one of them, and this is from the sponsor as well. It's a combination of naltrexone and bupropion, which is naltrexone is an opioid receptor antagonist, where bupropion is a dopamine and norepinephrine reuptake inhibitor. Essentially, in summary, the maximum weight loss from baseline is about approximately 5%, with common side effects of nausea, headache, and insomnia. That's what I'm familiar with, that patients experience, contraindicated with those with uncontrolled hypertension or those with seizure disorders, and etc. Right. Sorry. So how it works is that it really targets these two centers, which is the hypothalamic hunger center that I had mentioned earlier, and the mesolimbic reward system. So what they do is they essentially at the end of it is to reduce the hunger and reduce the craving by overriding the reward system. So how does it clinically, what it does is it is able to produce significant weight loss, as you can see here from baseline. In this study is approximately 8% from baseline. Significantly greater weight loss in the Contrave treated group, which seems to begin as early as week 4. So that's the advantage of it. You can see the result very early, and as well as that it can be sustained over a period of 56 weeks in the trial period. And the maximum weight loss is achieved between 28 to 36 weeks. So like most anti-obesity medication, you will see a plateau, and this happens if it happens between 4 to 6 months. It's actually a very good efficacy. In terms of yes,
sorry to interrupt you, but we lost your slides.
You have? Hang on. Oh, sorry, Geeta.
Okay.
Am I back?
We can see. Yeah.
Okay. All right. Sorry. How many slides did you miss? But anyway, okay. So in terms of improving glycemic control in diabetic patients, HbA1c reduction of approximately 0.6%, and with the weight loss as well. And then they report significantly less craving, 41% reduced desire for starchy food. So it seems to have an inclination towards those with sweet tooth compared to those with savory cravings. But overall, there is a 31% reduced incidence of food craving as well, and reduced strength of food cravings. As well as that, there's significant reduction in waist circumference of approximately almost more than 5 centimeters, and also improvements in the lipid profile, also fasting insulin and insulin resistance. In terms of adverse effect, nausea, constipation, vomiting, that's most common, mild to moderate in severity. And as you can see here, usually it reduces from between 4 to 8 weeks. So, and that's the reason why in the use of Contrave, there is an escalating regime that you use initially with 1 tablet and then 1 tablet twice a day, and then followed by 3 tablets in a day and then 4 tablets in a day. So most of them, so the weight loss seen in Contrave, it seems to be independent of the nausea. So it's not necessarily as the nausea reduces after 4 weeks, the weight loss continues. However, before the initiation of Contrave, patients should be discussed about what are the possible side effects. The other medications, as I will go through them very, very quickly. There is a combination with phentermine, topiramate, slightly more efficacy, almost reaching 10%, constipation, nasopharyngitis, etc. But this is not available to us. And GLP-1, going on to GLP-1 receptor agonist, which is a native peptide, has a central effect on the appetite, energy intake, and body weight. And I'm sure you are familiar to some of this, like dulaglutide, liraglutide, semaglutide, exenatide, lixisenatide, etc. So they are of different origin. So as you can see on the left is human GLP-1, and the other one is exendin-based therapies. Essentially, pharmacotherapy is essentially the same. So some summary across Saxenda clinical trials. It ranges in terms of efficacy is between 5.7% to 8% in body weight after a year. And but however, the different outcomes, significant outcomes in terms of reduction in the risk of type 2 diabetes, change in HbA1c, maintenance of 5% weight loss, and other events as shown here. The GLP-1 receptor agonist, I'm sure some of you may be familiar with this. The most common is the GI side effects, but it also has seemed to have some indication towards gallbladder disease and acute pancreatitis, but in more recent data, this has been shown to be quite negligible, and neoplasms are also similar to placebo, so quite safe. So in summary, it has a strong weight loss efficacy, almost up to 10%. It has a dose-dependent beneficial effect, 80% risk reduction in development of type 2 diabetes with 6.2% additional weight loss after low-calorie diet-induced weight loss. So the other newer pharmacotherapies in the market now coming to Malaysia, I hope currently very much available in the US and Europe, is the semaglutide 2.4 milligram weekly that you maybe could be familiar with the name of Wegovy. So it has not reached us yet. We're not sure yet when it will reach us. But as you can see, the mean change in body weight from baseline to week 68 was about almost 15% in the semaglutide group versus 2.4% with the placebo. And nausea and diarrhea were the most common. However, it is transient and it's mild to moderate, and it subsides over a period of time. Usually, in our experience, usually subsides after 4 weeks the most. The other one that we're expecting to be a bit earlier, I hope, is the combination between gastric inhibitory polypeptide GIP and GLP-1 tirzepatide. Essentially, it works very, very similar. It is a gut hormone as well. And the combination of this has shown mean weight change at 72 weeks of almost more than 20% with a higher dose, with those achieving more than 5% weight loss at 72 weeks, achieving almost more than 90% or almost 100%. And in terms of adverse events, the most common nausea, diarrhea, and constipation. So very quickly now, Prof. Geeta, and then in terms of newer therapies for obesity, you have cagrilintide that is coming not so soon, maybe more a few years down the road. It is a neuroendocrine peptide hormone consisting of 37 amino acids, and once weekly treatment for people with overweight and obesity in this multi-center randomized double-blind placebo-controlled phase 2 trial shows a reduction of body weight reaching over 10% body weight, and it's indicated in those above 18 years old without diabetes at the moment. And then we have just completed one study that is looking at the combination with cagrilintide and semaglutide, which seems to have very, very significant efficacy. But we have yet to see the results, maybe by later this year. So other similar hormones are the GLP-1 glucagon receptor dual agonists. We have the tripeptides, a combination of GLP-1, oxyntomodulin, peptide Y, peptide YY. And I'm not going to go through very much into detail because it's very early phase. This is in the earlier phase 1 and phase 2. So I'm not going to mention it too much. But just to highlight to you that these are the future of obesity treatment in terms of multiple hormonal targets that is utilizing all these injectable forms of medication. So in terms of body weight here, again, efficacy is seems to be quite various. So we have to see what are the other which hormones is the winner. But essentially now the two that is coming, which is Wegovy, and I'm sure you've heard of Mounjaro. So we are expecting those two soon. So just highlighting the algorithm for the South and Southeast Asian adults I had mentioned earlier. So just bringing your attention to at the end here. So if the pharmacotherapy fails, surgery is indicated. If BMI more than 30 kilograms per meter squared, or those with BMI less than 27 kilogram even with comorbidity. So what are the evidence on bariatric surgery is indicated with severe obesity and moderate obesity with complications. As you can see here on the right-hand side, the column on the right-hand side, the total body weight loss with surgical intervention versus current medical treatment, 20%, between 20% to as high as 37% with the Roux-en-Y. It really depends on which type that you have. The simplest one is probably sleeve gastrectomy, and that's pretty safe. So also I wanted to highlight that some of the medical therapies can actually produce similar results of reaching up to 20% at least with pharmacotherapy if it is accompanied by very good support in terms of diet and lifestyle changes. Right, in summary, obesity is a chronic disease. I hope I have emphasized that to you enough. And diet and lifestyle remain as a fundamental management plan. We should take note of, since we were talking about childhood obesity earlier, so annual increase in child obesity between 2020 to 2035 in the World Obesity Federation statistics is 5.3%, which is very, very high. And treatment of obesity should be considered early, i.e. either pharmacotherapy or surgery, and indicated as I had mentioned before. And the summary of this, and if I can just impress upon you that any weight loss, it's good weight loss, okay? Any weight loss. So what is required, however, obviously, if you have bigger weight loss, you have better medical benefits, including prevention of diabetes, hypertension, dyslipidemia, etc., and actually preventing or even pushing diabetes into pre-diabetes state and keeping it that for a long time. So if you have 15% weight loss, up to 15 to 30% weight loss, there is significant improvement of fatty liver as well. So all these improvements that patients should be able to know about when we talk about obesity treatment. So that brings me to this, just introducing Malaysian Obesity Society, which is supposed to complement MASO, yeah, Prof. Geeta. Our aspiration is to work together with MASO and highlighting the dire state of obesity in the country, and basically just getting people together to talk about obesity and to acknowledge that it is not a lifestyle choice. It is a disease that everyone should be getting their hands dirty to manage. Thank you very much.
Thank you, Prof. Rohana. Okay, if you could just end your sharing, you can.
Oh, okay, yeah.
Okay, thank you. So that we can see you clearly now. Thank you so much. You are very much earlier. uh, okay, just a few questions, Prof. Rohana. Maybe some audience would like to ask also. But while that happens, I want to ask you: when are we going to acknowledge obesity as a disease in Malaysia?
I think, as you know, but I think for a start, right, Prof. Geeta, you know that, when obesity has been put in a National Health Mobility Survey as at par with diabetes, hypertension, hyperlipidemia, that was a huge big success for us. I mean, that was the first step, I thought, personally. But it is not yet considered as a chronic disease for other purposes like reimbursement, budget, and all that, right? So slowly, I think we're getting there. I'm happy enough that we are creating a lot of noise and people are willing to talk about it and willing to, willing to acknowledge, let's go on the first step. So I would like to thank Ministry of Health for including people like us, right, Pravita and myself, Mayos, Maso, to be involved in this obesity conversation, to acknowledge that, it needs to be acknowledged, obesity needs to be seen as something that is treatable. I think a lot of people do not see it as something treatable. You just go like, oh yeah, it's the whole family is, overweight. Yeah. So, but when that happens, let's see who watches this webinar today.
There'll be some actions to what we are talking. I mean, it's about high time, in fact, because we have 54% of Malaysian to have weight issues. So this is really a very good time to be acknowledged as a disease. There's a question from Prof. Tila here. Perhaps, Prof. Rohana, if you could elaborate on the nature of weight loss, as much literature indicates muscle wasting is part of the weight loss.
Okay, so you're talking about obesity sarcopenia, which is an excellent point. So when in obese patient has been shown that they have a lot of as I had been underscoring initially, is the excess in adiposity or adiposity excess. So that kind of takes over their muscle. Even their muscle has got adipose tissues in it. So that makes the muscle, the function, contractility is compromised and reduced. And that further adds on to the reduce in metabolic rate, reduce in functional movements. So, those are the things that the consequences of obesity. So the way to do that's why when patients start to lose weight with whatever means that we say, some patients can do well. We have a low carb clinic, Prof. Geeta, and they actually can do very well with diet alone. But when they do that, then they lose muscle mass. When they lose muscle mass, they feel tired. They don't want to exercise. They lose their joints. So then it counteracts. It's counterintuitive for them. So that's what we say, that when you restrict your calorie intake, you will lose weight, okay? But you cannot maintain that if you don't put in the exercise bit. So that's what we usually emphasize on.
Yeah, so that's part of the muscle rehabilitation that you should be part of this pharmacotherapy approach. I mean, it needs to be, multidisciplinary. That's why we need those exercise experts as well.
Yes.
To be part of this. One Rokedon is asking, what is the rate of recurrence after one has done bariatric surgery?
Right. Perhaps I would like to just acknowledge that question by Dr. Rokia, that Malaysia has recognized obesity as a disease. And that's the thing that I want to highlight. Although we say, thank you very much, KKM, for putting this into the National Health Mobility Survey, but a lot of it is actually not yet recognized as a disease. It doesn't have it doesn't have its own budget. It's not reimbursable. And you can't even claim from insurance. Whereas you can claim anything under the sun for diabetes, for example. I'm exaggerating, obviously. So things like this, it's not really recognized as obesity as a disease yet. So we're getting there with your help and your support, as well, I'm sure. Okay, so the recurrence after one has done bariatric surgery, it really depends. And that's the reason why actually with the different BMI, the surgeons will decide whether they want to do the sleeve gastrectomy, or the bypass, because they are different. The sleeve gastrectomy is just restrictive surgery, whereas the bypass is a malabsorptive surgery. So they have a different, slightly different mechanism. So the rate also differs by which type. So the rate can be as, I don't know, it does perhaps even up to 50% of the weight loss they can regain, but the duration is really depends on the patient. So sometimes most of our patients will start seeing weight regain after a year.
Okay.
Some patients who are not well supported in terms of family members, etc., will experience weight gain even after 6 months. So that's the type of patients that we want to avoid, and that's the reason why for us endocrinologists, we want to work together very closely with the surgeon so we can support them after the surgery and before the surgery. So before the surgery, we help to optimize the treatment care to reduce more complications, surgical complications, and then following the surgery, we work together to avoid this weight regain.
Right. So it needs a close monitoring with them, I suppose. Yeah. So, Prof, I want to ask, we have like so many types of pharmacotherapy drugs that you mentioned in your presentation just now. It's beautiful to see that, but also I want to understand what is your opinion about lifestyle interventions. We've been telling our patient lifestyle is one of the most important. It's a cornerstone of any for weight loss. So with all of these drugs that coming, there's more drugs coming in. What do you think about the role of lifestyle intervention? Do you still emphasize about this? You have to eat healthily, you need to do physical activity, you need to reduce your stress, sleep well, all of that aspect of obesity. What is your opinion on that?
Absolutely, Prof. Geeta. A patient were to ask me, between you and me, I think you are more important because you will talk about diet and lifestyle first. Right? Because even with pharmacotherapy, and this is one of the messages that we want to bring out there, that currently the anti-obesity medications are being abused by certain industries. Okay, I should not name the industry. Okay. Unfortunately, they are also driven by demand. So like Wegovy so semaglutide is supposed to be current indication. Semaglutide 1 milligram weekly is indicated for diabetic patients. Okay, so not indicated for non-diabetic patients because there is supply shortage in globally, but because of the demand, so it's being currently used for non-diabetic patients. So then our diabetic patients are compromised because they don't have medications, and then they have they have discontinuation of treatment or transient So still, that is what we emphasize. And I will always say this, that the pharmacotherapy and even with surgical intervention will not work without an effective diet and lifestyle interventions first and foremost.
Right.
And by definition, the pharmacotherapy and surgery should only be offered with failed medical therapy, which is failed diet and lifestyle. So because for many, many reasons, so weight regain is one of them. So if they don't have diet and lifestyle in place, the pharmacotherapy is not a magic pill. It will somehow, you have adaptation as your basal metabolic rate drops with the weight loss because it's a defense mechanism. As you lose weight, your basal metabolic rate drops because the body detects it as a threat. So it lowers its basal metabolic rate. So that's one of the many reasons. I'm just oversimplifying it.
Yeah, right.
So you really need to. So if a patient, even if a patient asks me, how long am I supposed to be on this drug? And I will say, I wouldn't say lifelong, okay? You should be on it as much as it benefits you, then you continue on it. But more importantly is that you have got to change your diet and lifestyle. Yeah, so that's the main issue, because I said as you lose weight, you feel better, you feel lighter, you can do more exercises. So this is one of the things that we emphasize on. I completely agree that muscle rehabilitation is currently in the CPG. There's a whole big topic on it, and I think we have mushrooming exercise physicians, they call it, right? Yeah, and we want to, one of the initiatives for the National Strategic Planning that Prof. Geeta and myself are in is to enhance this training in muscle rehab and sports physician and etc. etc.
That's right. So hopefully more and more to come, and then we can do this as a multidisciplinary approach. Yeah. So that's good, because I'm asking you this question because people are thinking, Malaysian especially, they think they're taking the pills, they're taking the ubat, so they can eat, like anything like, without, taking into consideration of the lifetime intervention, because they're thinking they're on the drug intervention. I don't have to care about the lifetime intervention. This is the opinion or the perception of most patients in Malaysia, I think. Yeah. So we have to really emphasize the lifetime intervention at the same time when they are getting the pharmacotherapy help.
And I wish, Prof. Geeta, that we can do a lot more in terms of increasing the awareness of obesity as well as diabetes, because it seems it's the same thing. Patients will say, I can eat a lot more because I'm taking this drug already for diabetes, whereas it's quite reverse. And the medications are just astronomical in terms of price, and, I'm not simplifying it. Some patients really need pharmacotherapy, but for a lot more majority out there, actually they need to watch the diet, do some level of calorie restriction, and then they will see that their dependence on the medications will be reduced. So, this is the part that we have not been able to increase awareness among our Malaysian adults enough, I think. So, with this kind of webinars, we're hoping to reach out more to healthcare providers for you to be able to give this conversation or start this conversation, carry on this conversation that, you don't have to spend so much if only you put less into your mouth.
Exactly, I agree with that. So you and me, Maso and Mayos, we have a lot more to do in terms of increasing the awareness. Hopefully we can collaborate more in the future. Yeah,
absolutely.
With that, Prof. Rohana, thank you so much once again. Thank you, Ainawat, for bringing Prof. Rohana today in our sponsored talk today, and I hope we can catch up for more in future, Prof. Rohana.
Thank you, Prof.
Thank you so much. Thank you.
Bye.
Okay, so we are on time. We have third speaker here, Dr. Ginsky. Dr. Ginsky is a co-founder and access director of Angsana Health. He'll be talking about public policies and digital health solutions against obesity. Dr. Ginsky, are you here?
Yes, I'm here. Hi, Prof. Geeta, just to check, can you hear me?
Yes, we can hear you. Yes, excellent. We can see you as well. How are you today, Dr. Ginsky?
I'm good. I joined a little late, but I really enjoyed the talk by Prof. Rohana just now. It was really good.
Good. Good. Thank you, Dr. Ginsky, for accepting our invitation to talk here. I know this was supposed to be by Dr. Kaur, but for some reasons he can't make it today. But I'm sure you will do the justice. You excellent with your excellent CV. Let me just introduce Dr. Ginsky. Dr. Ginsky has 7 years of clinical experience in India and Malaysia. He is the co-founder and access director of Angsana Health, leading efforts to expand digital health access for the past 3 years. Dr. Ginsky holds a Master's of Public Health with a specialized stream in health economics from the London School of Hygiene and Tropical Medicine, and he is also a certified value-based healthcare practitioner by the VBHC Center in Europe. He's a Global Future Fellow in Predictive Healthcare with PIJA Foundation in Indonesia, as well as an adjunct lecturer in public health at Universiti Tunku Abdul Rahman. Dr. Ginsky is a strong advocate for public health and is also an author in various printed media. So it's our pleasure to have you here, Dr. Ginsky. So now it's over to you. The screen is yours.
Thank you, Prof. Geeta. I hope everyone is still fresh from the series of webinar that had just happened earlier. Maybe just to while I share my screen, if I may ask, if you could just introduce yourself, put your name or where you work, what's your position in the chat. I'd love to get to know you as well, even as I introduce myself. I think I'm given only 30 minutes, so I better be hush a little bit about time. So with that, Prof. Geeta, just to check, you can see my screen?
Yes, we can see your screen. Excellent.
Okay, I'm very honored to talk about public health policies and digital health solutions. Perhaps more of this session will be more on public policy, and it's a zoom out view of what how we look at obesity in Malaysia. Earlier on, we talked a lot about clinical, right? From the healthcare perspective, healthcare service perspective, which we will touch also. But this time we will be focusing a little more on a bigger picture. So with that, I'll just quickly introduce myself. Prof. Geeta has already just briefly read about my background. I'm a medical doctor, master's in public health. My interest is in value-based healthcare, digital health, as well as health technologies in general. I'm also a lecturer at Utah. And just to be very clear, there will be examples that I will be using from both public and private sectors that are publicly available. So I don't have any commercial interest to disclose, even as I share examples and case studies from around the world as well as in Malaysia. So with that, I'll begin with introducing myself as a childhood obesity survivor. I'm a proud child obesity survivor. You can see on the bottom right of the screen. Perhaps I was one of the two highest BMI when I was in primary school, and right now I'm very happy that I've overcome and I'm in the normal BMI range right now. But I have to say that the effects of having childhood obesity lingered until now. I noticed that I have body dysmorphia to a certain extent from all the bullying, from all the teasing when I was young because of childhood obesity. So today's topic is really close to my heart, and I hope that even as I relate my experiences to obesity, that I can share at least a little bit of insights on how the overview and the public policies, as well as digital health solutions against obesity, can be implemented in Malaysia. With that, I'll just quickly move away from the funny picture. So as you can see over here, there are many public policies already formulated in Malaysia. I just randomly put four, including one very amazing work by Meso, who is the organizer of this webinar, the strategy for prevention of obesity, right? So my point of showing this slide is to highlight how we have come up with so many policy options, so many ideas that we have had entertained in the past on how to solve obesity in Malaysia. The sad truth is that as you can see in the middle of the screen, while we have so many policies, so many activities that we are doing for obesity, obesity rates seem to be continuously climbing throughout the years. This is a sad reality despite all the great efforts that all of us have put in from public sector, from private sector, from academia, and just a sad truth. So therefore, because we only have 30 minutes, right, for my talk, I cannot deep dive into each of the policy that we have had. So I handpicked three main areas, and they are here. Fiscal policies, which is related to money, food environment policies, as well as policies that are related to healthcare services. And I've handpicked this because I think our audience today is mainly from the public sector, as well as some private sector, but also many academicians here as well. So I hope to be able to highlight some of the gaps that we all can play together to help improve the status of obesity in Malaysia. And within each of these categories, these policy categories, I'll be sharing about case studies, global best practices, and then we will compare how is Malaysia doing compared to the benchmarks that I'll be sharing. And finally, we will have some analysis, some speculations and gaps. The reason for speculations is because nobody knows the whole picture, right? The whole truths, because I'm not from the ministry side, so I wouldn't know what's being implemented and what is the status of each implementation, right? We can only speculate, and there are many things that are ongoing that we don't have data yet to conclude whether it's effective or not. So there are many things that we have to speculate, but I think it's fun for us to all speculate together and analyze together and see what are the gaps that we can potentially play. So with these three categories, I hope to share some insight, and we will end with a Q&A as well as some sharing. If anyone wants to raise your hand or you want to ask a question in the chat group, the Zoom chat, please feel free to do so. So, okay, we'll start with fiscal policy, right? This is the assumption. So fiscal policies, fiscal means financial or accounting, if you're more familiar with those terms, where we influence food behavior by controlling prices. So the assumption is that consumers are price sensitive to food and beverages. So for example, if we put in a sugar sweetened beverage tax, SSB tax, right, we will increase the price of those drinks, those beverages, and thereby reducing the purchase and consumption. So that's one way of reducing the consumption of sugar sweetened beverages. As a bonus, manufacturers will hopefully reformulate their beverages with reduced sugar so that they reduce cost, because sugar, they need to pay more for sugar, for example. And the bonus is that those who are not sensitive to price, if let's say you buy a can of, say, Coke, for example, or Pepsi, used to be 180, now it's 250 per can, and you don't really mind. So you belong to the price insensitive population. But because of the price sensitive population, now the manufacturers are reformulating Coke Diet or Coke Zero, for example. And now we, you or we who are not sensitive to price, also have access to beverages with reduced sugar. So this is one very simplistic way of describing the mechanism of fiscal policy in influencing food behavior. At least this is the assumption. Now we're going to go through one by one, okay? Case studies, how is Malaysia doing, and some analysis at the end. Okay, let's do some case studies. And if I may focus your attention on the left side of the screen, right? The map is only showing how are SSBs being designed all over the world. And I've handpicked 3 countries here, and before we compare Malaysia with them, okay? So in Mexico, Mexico started 2014. 1 peso, that is about 20 cents per liter of the SSB, sugar sweetened beverage. And the result is that there's 37% reduction in the total volume of drinks purchased. Whereas in the UK, there's about 1 ringgit per liter for drinks with 5 to 8 grams of sugar per 100 ml. Or if the drinks has more than 8 grams of sugar per 100 ml, it's about 1 ringgit and 30 cents. And there are studies that show the reduced daily free sugar consumption in children by 5 gram and 11 gram in adults. So all of these data are available in the link. If you like the slides, please feel free to reach out to me at the end. And South Africa also has implemented this since 2018. And the result is that there is decrease in purchase of carbonated drinks by 29%, and sugar that is consumed from those drinks decreased by 51%. Now, these are success stories, if I may, and of course, I've presented it this way to you so that you can see, right, how much the impact of SSBs around the world. Now, let's look at Malaysia, and I'm sure all of you have already know that we have implemented SSB tax since July 2019. That is 40 cents per liter of drinks for those with more than 5 grams of sugar per 100 ml. For fruit juice, vegetable-based drinks, that is with more than 12 grams of sugar per 100 ml. That's what we have already implemented. Now, there are some efforts that are ongoing in Malaysia as well. For example, in the 2024, the recent National Nutrition Survey, I think they're in data analysis stage right now. I'm not sure about this, but they have included sugar intake as one component in the survey to ask people around how much sugar they've taken daily, for example. And there are other implementations as well. We have seen in the recent news that SSB may increase by 20% from 40 cents to 50 cents. And then there's Healthier Choice logo, which you can see on the right side of the screen, where some of the products, right, they have this Healthier Choice logo if they achieve a certain criteria, whether it's low in sugar, low in fat, low in salt, and so on. Then there's a My Choice initiative. And there are also plans to expand SSB tax to condensed milk creamer and cordial mixes, because there have been many, I wouldn't say backlash, but rather feedback from the public. How can you tax just sugary drink? Why not condensed milk? Because that's where most Malaysians drink, right? So and if you can see on the bottom right of the screen, there is a Milo truck, and if you can read on the picture, right, your healthier choice. So when I was small, I used to enjoy, which I'm sure many of us did when you were younger. Milo truck, somehow it tastes different, right? Compared to the Milo that you make yourself. The misleading part is that they labeled themselves as healthier choice, which after I grew up and I became a doctor, then I realized how much sugar was within each cup of Milo, and I've stopped drinking Milo since then. So even today, Milo still has their food trucks in sports days in primary schools. Not only that, there are some fast food chains like McDonald's that sponsor football games, for example. So there are many things that these F&B industry are doing, right, in terms of marketing that are not regulated, they are not forbidden, especially when they market to children. So with the fiscal policy that I've shown on the left side of the screen, right, comparing with Malaysia, we are slightly lagging behind, if I may, because as of today, we don't have data to tell us whether the SSB tax in 2019 have really impacted sugar consumption or not, at least that is publicly available that I can find. So we've talked about case studies globally, we've talked about Malaysia. Now let's do some small analysis. The question is this, 40% okay, 50% okay, but is that high enough to influence Malaysians' behavior? If you look at Mexico, it's 20 cents only equivalent, and they have a significant reduction. South Africa is half a cent, and they have a significant reduction. United Kingdom is RM1 equivalent. But if you compare the median income versus the price of SSB that is affected by the tax, Malaysia is actually considered a high tax, 50 cents, if we compare the median income with Mexico and South Africa, for example. Of course, our median income is lower than UK, but if we compare it together, our 50 cent is actually quite high as a tax. But till to date, we don't have data to support whether or not it is truly effective. So what we can do is just speculate. I think it will work. I think especially people who so there is a white known, or rather, let me put it this way. I would speculate that the population that are suffering from obesity are largely those that may come from lower socioeconomic background that will be affected by the price hike because of the sugar sweetened beverage tax. So that is one hypothesis, and it's yet to be proven, at least in research. If any of us here are academicians that are doing research or have done research regarding this, the impact of SSB on sugar consumption or consumption of SSB, please go ahead and put a link of the study that you've published, or you can just say that you are doing the study. I would love to speak with you after this, just to have a chat, right? So that's one analysis that I put up. Now, the second thing, if I were to relate it to digital health solutions, the question is, how can technology inform this proportion of price hike due to SSB and suggest lower sugar alternatives? For example, let's say you want to get a can of Coke in 99 Speed Mart, for example, and you pay with your e-wallet, for example. Can your e-wallet notify you that Coke has increased price by RM1, for example, compared to 10 years ago because of SSB? And why not you try a lower sugar alternatives, for example? This is one way that technology can immediately nudge the consumers already, that you are paying more because of the sugar tax, and there is sugar tax because it's deemed unhealthy and it leads to obesity, diabetes, and so on and so forth. And to suggest lower sugar alternatives, this is technologically possible, and something that maybe some of us may be interested to consider an experiment. Now, if I may move on to the second point, can there be a no effect on sugar consumption despite reduction in SSB purchase? That means the SSB tax, is it possible that it may not work? Right now, we're speculating. So the premise of this speculation is that Malaysians drink more made-to-order drinks than SSBs. So made-to-order drinks are like teh tarik, your kopi ice, your cham, whatever that we order in the kopitiam or mamak. Those are made-to-order drinks. And the premise of this speculation is that we don't really buy canned drinks, we don't really buy sugar sweetened beverages. We drink more of those things. Those things contribute a high proportion of sugar intake or caloric intake in our daily life. So if let's say we implement SSB tax, there is a possibility that it doesn't work, not because the tax doesn't affect people's decision, but because we just don't drink SSBs as much as we drink made-to-order drinks. So there is one possibility that it may not be effective. So then the next question is, how can technology be used to amplify behavioral change? One example that I gave was the digital nudges from e-wallet purchases. And for example, if you buy groceries, your e-wallet is technologically possible to track your sugar intake from purchase history. It just has to have a few layers of data analysis, right? What you've bought and what is the nutritional information within what you've bought, and just compile it on a daily basis. And this can create a nudge to the user. Oh, actually, you're consuming more than you're supposed to consume. Or if you're buying it for your family, your groceries, if you're finishing your groceries within a short period of time, the calorie intake is actually much higher than is required for your entire family. So technology can very easily be used to help nudge consumers' behavior. And finally, how effective are the logos, right, in influencing Malaysia's behavior? The my choice logo, healthier choice logo. Right now we don't really know. I can't really find a study that has been published on the effectiveness of this policy that has been implemented. And in fact, if I were to bold enough to say that many of our public health initiatives don't really have a proper monitoring and evaluation. We implement a lot of campaigns and initiatives without really knowing whether they are effective or not. So therefore, there is a huge gap over here. If I may invite my friends from the academic side, why not analyze public health initiatives, whether or not they are effective, the effectiveness, the acceptability, people's behavior towards them, those things, a lot of gaps, and we don't learn from our mistakes because we don't know if they are mistakes or not. So this fiscal policy that we've implemented in Malaysia, it's still relatively a black hole at the moment. So finally, on the bottom right-hand side of screen, I put, how can digital health gamify these logos? How can we create sort of a motivational game, right, for people to adhere to healthier choice? And this is something that maybe the private sectors may consider as well, to provide rewards, right? If a consumer consumes let's say a streak of healthier choice foods, for example, I think this would be really fun. So in favor of time, I hope I have at least piqued some interest from all sectors to consider the gaps that are in the fiscal policies that are being implemented in Malaysia. So I'll move on to my second slide. Over here, food environment policies, right? Where we influence people's food behavior by controlling the food environment, not exactly what they eat, but what is available around them. So the behavior engineering that is very smartly done by a lot of industries is those unhealthy food are presented with bright colors, animations, happy emotions. I can immediately imagine McDonald's already. You have Ronald McDonald playing with the kids. He's dressed as a clown. The color is yellow. There's red. There's a lot of psychology behind why they do what they do. And this unhealthy food is associated with fun, cool, delicious, special treats. How many of you have gone to eat fast food or Western food on special days or special occasions when you were young to celebrate your finishing exam? Otherwise, your other days are you eat at home, you eat relatively dull, tasteless, healthy food, or your parents, I mean, your mom would cook for you. So there's a lot of association of those unhealthy food with special treats. Even right now, if someone gets sad, for example, or you want to go and eat cake, if you're guilty, you can put a laughing emoji in the Zoom chat. I'd love to share the fun with you. So with all of these associations, if we are exposed repeatedly to them, it creates a positive reinforcement and craving. And if you can identify, you can put on the Zoom chat lah. So over time, these unhealthy preferences and habits develop. They become part of your lifestyle already. And this whole thing is very insidious and very stealthy. Behavioral engineering, where the industries change our behavior without us even knowing it. And after 10, 20, 30 years, now half of Malaysians are obese or overweight. So this is a result of behavioral engineering. Now let's look at the global best practices on what they did with their food environment. In the UK, they have explicitly banned the advertising of products high in fat, sugar, and salt on TV and social media. So in UK, you cannot find any advertisements of unhealthy food on their TV. Not only on TV, social media also. Facebook, Instagram, those are the things, those are the places where people scroll and spend most of the time daily, and they've banned it since last year. So the intention is to reduce children exposure to unhealthy food ads and to promote healthier product reformulation, meaning if the industry would like to put on an ad on TV or social media, they have to adhere to what is the criteria or the threshold to be labeled as a product high in fat, sugar, and salt. So they will reformulate their products in order to adhere, so that they can advertise, and in the end, it's good for everyone. So they reformulate their products, they get to advertise, and people get to eat healthier food. Now, if you look down to the second example in Chile, they have put something known as the mandatory nutritional warning black label, as you can see on in the middle part of the screen. So that's so high in azucares. I don't know what's that. Sorry, I think it's sugar. Calories, high in calories, then high in saturated fat, high in sodium. They have put mandatory black label warning in the products that they get in supermarkets and groceries. So the result is that there is a reduction, 23% of purchase from products with high in calories, 16% high in saturated fat, and so on, as you can see over there. And not only that, Chile was actually the pioneer of this black label, and it was followed suit by other countries as well. Right now, I think that mostly in the European countries, they have done this already because it's effective. Thirdly, third example is Singapore. Nutri-grade system is what you can see on the bottom middle part of the screen to grade food products, whether they are high in sugar, low in sugar, good. They will be graded A, B, C, D lah. And the good thing is that D grade is banned from ads, and not only these Nutri-grade would include manufactured products, they also include made-to-order drinks. So things that we buy from kopitiam, we buy from restaurants, we buy from warung, for example, they also have Nutri-grade for this, and it's displayed on the menu that the restaurant has. So one important point to note, if you notice from this food environment policies, is that they have very hard policies. They ban things, they mandate things. There's no choice. It's not a voluntary. It's not an option for the industries to follow. These are mandatory hard policies. Now I'll move on to Malaysia, and you can see the stark difference. Malaysia has always implemented soft policies, not always 100%, but mostly we implement soft policies. For example, first example, Malaysian Food and Beverages Industry Responsible Advertising to Children Initiative is a pledge. Pledge is a voluntary pledge by companies like Coca-Cola, for example. There are, I think, 8 to 12 companies that have pledged to this, but they still advertise to children because it's voluntary and nobody is enforcing it. Then we have kurang manis, kurang gula, kurang harga. Suku-suku separuh is one famous one that our KKM has been doing quite well, I would say, because nowadays when I eat, I'll take suku-suku separuh already. I think the campaign is quite effective on me. But it's still a campaign. It's still educational, health promotional. It's still voluntary. If you choose to eat suku separuh, where half is rice or half is fried chicken, for example, you can still do that. No one's going to stop you. Then there's infographics on social media, Facebook. I think the Public Health Malaysia has been posting a lot of infographics. There's health promotion with influencers and politicians. We're getting more modern, we are working with social media influencers and politicians to promote good health. Then there's a healthier choice or my choice endorsements. There's also a lot of guidelines that we have published. But all of these are very soft policies, meaning they tend to educate people without enforcing, without monitoring whether or not they are really effective. Monitoring is the one that is missing over here, more important than enforcement, because education can work, provided that you get data and you check how much it actually works, even if you don't enforce it, right? So the stark difference between Malaysia and other countries is that Malaysia has always enforced soft policies without any enforcement. So now let's analyze this a little bit. Are the existing initiatives effective? I can tell you the answer is nobody knows, because nobody tracks it, nobody monitors it, nobody evaluates it. So therefore, I would invite my friends from the academia for research topics, for example. There are already so many policies that have been implemented in Malaysia against obesity. Nobody is checking whether or not they are effective. This is one huge gap. If we can tell, for example, that suku-suku separuh has effectively, changed the lifestyle with defined criteria. Of course, what's the meaning of changing lifestyle, right? Let's say if you can define it and you can monitor what is the effectiveness, then we know out of the 10 campaigns that we do in Malaysia, which ones are the most effective and why are they effective? How can we extrapolate that to other campaigns in the future as well? So this is where the huge gap that we have in Malaysia. Secondly, how can digital tools be used to shorten the learning cycle, meaning data collection, data analysis, data dissemination, all these things? How can we use technology to shorten the learning cycle so that whenever we roll out one campaign, we get the learning points as fast as possible so that we can tweak the next campaign? so that it doesn't take like 2 years in order to find out the effectiveness of a public health campaign that was done earlier. Then it'll be too late already. By the time obesity has risen, healthcare costs are rising, and it's too late to make any changes already. Then a more fun question would be, what will it take for Malaysia to adopt hard policies? The answer to this is we all become politicians lah. We go and change the policy making. It's not as simple as that, because an organization as large as the Malaysian government has a lot of bureaucracy for good and for bad. It is necessary that things go through the proper channel. It is necessary that things are overanalyzed, because there can be a lot of unintended consequences in each public policy that is being implemented. So therefore, what will it take for Malaysia to adopt hard policies? There's no right answer to this lah. But the but is that if you can see from the smaller bullet point over there, how can smaller organizational units play a role in pioneering policies against obesity? If there are people here from the academia, for example, can your university pilot a policy against obesity? Can your university mandate that your students or your staff do a certain thing? For example, you cannot take the lift if you're going up one floor or 2 floors, you must take the stairs, for example, mandate it. How can small organizational units like schools, for example, implement harder policies just to try it out, and then you come up with results, and then you can say that, oh, we have evidence that hard policies do work without significant backlash. If you're from the private sector, if you're from corporates, for example, how can you mandate your employees to adopt healthy lifestyle? Mandate your employees to adopt healthy lifestyle because it affects productivity at work. If your employees fall sick, if your employees have complications due to obesity or the non-communicable diseases, it directly impacts productivity at work. Therefore, the company is incentivized to create hard policies for employees to maintain their health. So something for us to think about. And finally, how can digital tools be used for monitoring and evaluation, which is similar to what I've shared earlier on shortening the learning cycle. All of these mini experiments that we do in smaller organizational units, defined as anything that is not government, schools, universities, companies, we can play a role in trying out hard policies, and then use the digital tools to give us lessons and learnings from there, and then we can always present it to the higher ups our findings. So this is a nutshell on food environment policies that I'd like to share with everyone. Now I'll go to my next slide over here, which is the last and final section on healthcare services. This is a gap that many of us would agree. So whenever we talk about obesity, whenever we talk about weight loss, people do receive inconsistent or generic advice. Inconsistent advice is like, oh, should I eat rice? Should I not eat rice? Oh, that doctor says you should eat less rice. That doctor says you should eat brown rice. That doctor says you should. There's a lot of inconsistent advice, and people get confused. And if you're confused, you don't know what to do. Generic advice example, yeah, eat less lah, exercise more lah. That's how the typical answer, generic answer for weight loss, right? But we know obesity is multifactorial. We know obesity is much more complicated. Although if you really practice eat less and exercise more, you would lose weight lah. But it's more complicated than that, because obesity is behavioral. So therefore, generic advice also does not help. Now, the second part is that incorrect advice is the worst. Magic supplements, you go and drink this shake, that formulation, this tea, for example, you have detox and lose your weight, right? These are a lot of non-evidence-based advice that are dangerous. And because people are bombarded with so many incorrect advice, inconsistent advice, or generic advice, that leads them to low motivation and adherence. Because if you tell me that, let's say, something as simple as drink eight cups of water per day, I can adhere to it. But if one person tell me 8 cups, another person tell me 10 cups, another person say, oh, actually you don't need to drink water. Your fat can produce water in your own body, for example. This is spurious advice. Then that leads to confusion, low motivation, and adherence, because you can't even adhere to something that you're not sure about, right? And finally, that leads to weight loss and regain cycles. You do something and you feel, oh, it works, and then you lost the motivation and you rebound again. And that happens to many people, including myself when I was younger, struggling through childhood obesity. So this healthcare gap, let's look at some case studies on how other countries are overcoming this healthcare gap. So in the UK, they have a NHS digital weight management program, 12-week online program, fully online for those with obesity, but you must have either diabetes or hypertension or both. And this is referred to by the GP or pharmacist and is fully subsidized by the NHS. They have a mean weight loss of 3.9 kg. This was a recent study in 2024. The qualitative study indicated that patients appreciated the convenience and spoke more openly, meaning compared to going in person to a clinic, for example, to speak with a doctor, it's quite a hassle to go there and you have to wait the queue, and then the doctor doesn't have much time for you. And you can't even speak as freely as you can compared to an appointment basis where it's online and you're at home, right? Because the time slot is blocked already for that person. Secondly, in Finland, they also have something similar known as the healthy weight coaching. It's a 12 months instead of 12 week. There is a dedicated personal coach, and it also has to be referred by a healthcare professional, a doctor in this case, also fully subsidized by the government, and they have a mean weight loss of 4.3%. This study was done in 2022, so I don't have the latest data for now. So there is a global trend towards digital and not only digital, but also multidisciplinary care for obesity. It's no longer just a doctor. It's no longer just a personal trainer. It's no longer just a dietitian or a nutritionist. It has to be all to care for the patient together. So let's look at Malaysia, where we are now. The weight loss initiatives that are in Malaysia must have been shared already by Prof. Rohana earlier, and perhaps other colleagues as well in the other webinars before this or even after this. But I'll list down some of the ones that are more well known. Klinik Kesihatan, if you go to a Klinik Kesihatan in government and you say you want to lose weight, they depends on which Klinik Kesihatan that you go, but they don't have a structured weight loss program for most people, for most Klinik Kesehatans. Klinik Kesihatan is a health clinic for those who are not familiar with Malay language. Peka B40 is a program where government pays, subsidizes the screening for your weight measuring. There's some blood tests, but that's only for screening. That's not intervention at all. For those that are screened to have obesity, they will be referred away from the Peka B40 program. Then there is a multidisciplinary team obesity clinic in many KKM hospitals, such as KL, in Putrajaya, and Universiti hospitals as well. Then we'll move away from public sector to private sector, right? GPs, private hospitals, some of them have structured some of them have structured weight loss program, but many do not have integration with online care. So a lot of times patient has to come in once a month or twice a month to follow up for consultation. And there are some that are beginning to use teleconsultation already because weight loss coaching don't need a physical examination. Then there is individual or organizations composed of dietitians, nutritionists, physical trainers, some doctors with sports medicine as well, does weight loss. Then there's corporate wellness providers where they coach employees of companies who are willing to pay for weight loss programs for their for their staff. Digital health, KKM is doing My Champion, My Sejahtera. If you don't know this, there are many health promotion activities that are in My Sejahtera, and even on their Facebook as well, to teach people about what is healthy, how do you take care of your health during Ramadan, for example. There's a lot of health promotion efforts, but none are really directly intervening with obesity. Then the private sector has Naluri and Sons, Angsana. Angsana is where I work, and we also have a digital weight loss program that is structured and evidence-based, of course. Then moving on from that is wearable smartwatches. They tell you about the steps that to take. These things, they contribute towards fighting against obesity because it calculates calorie burn from an exercise, for example, or the number of steps that you take. It tracks your weight, for example, but they are mostly self-managed. So Malaysia has many scattered, if I may use the word, scattered weight loss or initiatives that are not as structured as what is in UK, what is in Finland. There is also a not fully integration with the offline world and the online world for the convenience of patients in Malaysia. So let's move on to analysis a little bit. So question is, what are some guiding principles for effective weight loss programs? Evidence has shown that weight loss is it goes beyond a diet and exercise. There's a lot of behavioral aspects as well. So emotional, and I'm sure a lot of us may be familiar with the term emotional eating, whether we overeat, whether we binge eat, whether we eat when we're stressed or we eat when we're bored. Emotions play a lot of role compared to just tracking your calories. Then there's habit formation. That's why advertising unhealthy foods to children are bad, because they create habits from small that will last throughout adulthood, and then it goes beyond point of return already. So there is an emotional part of behavioral. There is a habit formation. There's nudging as well that have been proven to be successful in many of the programs, including the one in Finland. There's a lot of nudging involved. Once in a while, you receive a text message, and finally, it's outcomes based. So I'll wrap it up with using my familiar example, which is from Angsana. The weight loss program caters a lot to behavioral insights. So addressing emotional eating, addressing how to form a habit. How do you lose an old habit and form a new habit? Then there's a lot of nudging involved to keep the person continuously motivated, and it's outcomes based. So you track the waist circumference and your weight, and then there's a reward at the end as well, at the end of the program. So how can structured weight loss programs like this be accessible? And what is the extent of task shifting possible, right? Meaning, traditionally, healthcare has we've always regarded doctors as the main primary person to look to for health, right? But there is actually a lot of things that should not be done by doctors and don't have to be done by doctors. We have a great team of nutritionists and dietitians, great colleagues in behavioral science, in physical trainer, for example, that doctors don't have to do these tasks anymore, and they don't do as well as our dietitian colleagues anyway. So there is a lot of task shifting that is possible away from doctors, especially in GP clinics and clinic kesehatan, where there is a lack of allied health sciences staff. There is a lack of dietitian everywhere in primary care. Primary care is supposed to be the first point of contact for patients, and we don't have the experts experts in diet, experts in exercise there, because doctors they are trained in diagnosing, in treating medical conditions that are less related to lifestyle. Of course, now there is a movement towards lifestyle medicine, and that is good. But still, we should shift the task to the right expert at the right time, at the right place. And secondly, about task shifting is there are a lot of things that can be shifted away from humans even. So for example, diet analysis, dietary data collection, diet plan generation, all of this can be done by AI already. And that is something that Angsana is doing with IMU University to use AI to streamline nutrition care. So finally, how can subsidized programs include obesity interventions? Government, B40 that I've given the example, it's only screening. How can we put in obesity intervention as well? Employers have employee benefit. You can go and do your dental checkup, your health checkup every year. Can we also include obesity intervention in them? Insurers, they have a lot of also preventive care. If you don't claim, for example, you get a no claim benefit, and you can go and do a health checkup, a dental checkup, for example. These are also screening for people who don't claim, meaning they're healthy. We should have subsidized programs to intervene in obesity so that we avoid complications in the later parts of life, right? So this is a question that we all have to ponder. How can we include obesity intervention in subsidized programs? And finally, what are ways to increase their financial sustainability? So part of my work in value-based healthcare and health economics as well is to look at how healthcare financing can improve people's behavior, right? And one of the model that we look at is called shared savings. So for example, if I pay every year, every month I pay for my insurance. I'll just use insurance as an example because it's straightforward. And let's say at the end of 1 year, I don't claim any money, right? That there is some sort of savings that I have paid for the premiums that I paid. And because I have kept myself healthy, we can consider part of the money that I've paid to be given back to me for being a responsible person to take care of my health. And these can expand to even employers, for example. If I don't fall sick, if I don't take MC, if I don't go to the panel clinics to see a GP doctor, for example, can I take back a portion of that cost that I've saved in healthcare because I've kept myself healthy? So these are many models that this is one model, sorry, of many models that we can explore in increasing the financial sustainability to make people be responsible for their health, and they get rewarded for it because they save money from spending healthcare, because the payer is not them, right? Payer is employer or insurance. Okay, I think I've given a bit of bits here and there on fiscal policy, on food environment policy, and in healthcare services, the gaps. And I've also identified what are some rooms that we can play around, whether you're from academia, whether you're from private sector, whether you're from public sector. So in favor of time, I would love to speak more if it's possible, but I think it's 4 o'clock already. So I've completed these 3 small parts that directly bring together how public policies and digital health solutions can play against obesity. So with that, I'd like to thank everyone for your participation, for listening as well. If you have any question, please go ahead and put in the Zoom chat, and I'll pause here. Back to you, Prof. Geeta.
Thank you, Dr. Ginsky. That's very good. I really enjoyed your talk. Quite a number of things that we always what we mentioned, like for example, the lack of evaluation programs or evaluation research on whatever policies that we have, whether the activities, the programs that we run at the Ministry of Health levels are effective. I mean, there are a lot of things that is not available yet. So you have nicely highlighted those things as well. So maybe in future we can use these digital solutions to address those gaps that we all kind of know. I think can I ask one question to you, Dr. Ginsky? I just want to ask, do you know if there is any available digital health landscape in Malaysia that has done work that has addressed the multi-ethnic population in Malaysia?
Sorry, Prof. Geeta, if I may clarify your question a little bit, you're asking if there's any digital health solution for obesity?
Yeah, for obesity, for any other NCDs, anything of that, for multi-ethnic populations such as back in Malaysia. Do you know if there is any solutions, digital solutions to cater the multi-ethnic population in Malaysia? So that's my
question. Thanks, Prof. Geeta. That's a very specific question, catering to the multi-ethnic populations in Malaysia. The short answer is no, we don't have. What we do have are digital health solutions to intervene for obesity as an overall, and we look at the whole population as one, rather than segregating them into different ethnic, and to see different interventions or to tweak different interventions based on the different ethnicities. We don't have that, unfortunately, but that's a great idea, Prof. Geeta. Yeah.
So maybe we can share the one that you have with the overall population. You, as in the Angsana, probably have some solutions.
Yes.
Maybe you can share with us, Dr. Ginsky.
Of course, very, very happy to share that. So Angsana has a program called FIT10, FIT-10. So it's FIT10. FIT10 is a 3-month program led by a nutritionist, and it's completely online. It also has to be referred by a GP or a doctor, because the doctor has to assess the patient first. And the patient will undergo this 3 months program where patient has to submit their diet diary. They have to take photos of their food, get their food analyzed, get a diet plan generated by the nutritionist, and then we are building AI into it right now. So not only there is a nutritionist, there is also a lot of behavioral insights, such as nudging, such as motivational interviewing. And if the patient manages to lose weight at the weight goal, right, that is set with the GP, the doctor at the beginning, at the end of 3 months, the patient get a cashback reward for working hard together with the nutritionist. So it's a very strong behavioral insights that we put in the FIT10 program. So yes, Prof. Geeta, this is the FIT10 that is by Angsana that I'm most familiar with. Of course, there are others as well. There are companies like Sons and Naluri as well. I think they have a weight loss program. Back to you, Prof. Geeta.
Yep, I heard that Naluri has this weight loss program as well, and they also use this nudging approach in their weight loss program as well. Do you face any particular challenges while doing these digital solutions to our Malaysia?
Yes, definitely. There are many challenges, in fact, but what the 3 most common challenges that we face is patients' motivations are the ones that we need to cater to, and because we can never I'll admit now, healthcare services cannot be 100% digital. No matter what we do, human touch is very, very important. And if there is human touch involved, there will be a lot of time and emotions from the healthcare professional side to invest into the patient. So there are a big chunk of components or motivations or behaviors or emotions of the patient that we have to invest in. And if we have to invest in, that means we need the big team to invest in them, despite all the digital tools that we have provided. So the first challenge is, no matter what we do, people will still follow their heart. If they are tempted, they will still go and eat things that they are not supposed to eat. So number one is people's behavior cannot be 100% changed despite digital tools. Number two is there are some people who may not be so tech savvy when it comes to digital solutions, and not just the baby boomers. Some millennials also are not so familiar with tech, and that was surprising to us. People who are relatively middle-aged, who are supposed to be able to operate laptops and phones, they are the ones that have some trouble with tech. So these two challenges are very common in the programs that we run. Back to you, Prof. Geeta.
Yep, I agree with you. There's always a challenges with with the access and to access to IT in this case, or to ensure the adherence. It's always a problem when it comes to digital solutions. But also, Dr. Ginsky, in most of your slides just now, you did mention about the government, how government can play a major role, and we're talking about this because the theme for this year is also changing. It's at system levels. We're looking at the system level, and this is where government can play a role. So I just want to ask you your opinion. How can government integrate digital health to enhance, for example, the public obesity interventions?
Yeah, that's a great question, and very difficult one for me to answer, because firstly, I don't represent the government and I'm not within the government. Secondly, there's a lot of speculations, only speculations that we can do. What my opinions are is that, firstly, I think the government is doing a great job. They have already set up a digital health office, health transformation office, right? And there is a strong digital health team that is in Malaysia that is working on the MySejahtera, and they have done a lot of great things already. If you check your MySejahtera now, you can see how many times you've donated blood, where you can make appointments for Klinik Kesihatan for your vaccination, for example. There's a lot of initiatives that are already being done by the government. Whether or not they will integrate firstly, screening for obesity, for example, check your weight or waist circumference, for example, or to add interventions for obesity, that remains a decision that only government will make. And I can speculate that the thinking process behind obesity and digital health within the MySejahtera, for example, is among all the diseases in Malaysia, which is the most prevalent, which is the one that they need to target and prioritize first, that will be discussed in their meetings in government. That this is what we can speculate for now. But the timeline always depends on the government. I can't speak for the government, but I can only speculate for now. I hope that answers the question, Prof. Geeta.
You did, yes. And I think to convince the government, we also need more data and to see whether the any of these digital solutions is effective at all. That probably will convince them further. So I hope to work together, or probably other academicians in this platform would like to work together with Angsana, and so that we can have more data in hand to convince the policymakers in future. Yeah, and Rohana did mention that she agreed that the healthcare delivery to patients still needs emotional inputs to improve their motivation. So the nudging have to be really very much personalized to mood, to motivation, and so on. So there's a lot more challenges, I suppose, Dr. Ginsky, that probably we can work along, and we need data to prove all this, I suppose. Yeah. So thank you so much, Dr. Ginsky, for your talk. It's really, really very comprehensive, very good. Long way to go, I guess, for digital solution, but we are there. With Angsana, I suppose we are there. Yeah.
Prof. Geeta, you're very welcome, and thank you for allowing me this opportunity to share some of my thoughts. I hope the audience has enjoyed, or at least got got something out of it. And if you like to connect, you can always write to me. My email is there on LinkedIn as well. I'd love to have more coffee chats to talk about policies, talk about digital health services in Malaysia. So thank you very much once again. Back to you, Prof. Geeta.
Thank you, Dr. Ginsky. Okay, so we have come to the last speaker now for today, and I hope we can finish before 5. We have Dr. Claudia Abreu Lopes. She's research lead, digital health, United Nations University Institute for Global Health. She'll be speaking on digital health solution for obesity prevention and management, looking into the equity consideration in design and implementation. Dr. Claudia is as I mentioned, she's a research lead in digital health from UNUIIGH. Expertise lies in the structural determinants of health inequities and digital health governance with a focus on sexual and reproductive health, mental health, and gender equity. She holds a PhD in social research methods from London School of Economics, LSE, and an extensive academic background in psychology and social sciences. She has held academic positions at University of Cambridge, LSE, as well as University of Coimbra. Her research spans Europe, Africa, Asia, working with international organizations such and also civil society. Dr. Lopes has led multiple high-impact projects, including research on community health workforce, gender equity, digital media, role in public health communication, and also big data applications for gender equality. And there's a lot more of Dr. Lopes, what she have done so much, but she is a consultant for UN Women, the World Bank, and other global organizations, leveraging digital health and analytics to inform policy and social change. So hope to hear more about how we can leverage on digital solutions to inform policies to improve or prevent obesity. We want to learn more from you, Dr. Claudia. So over to you, Dr. Claudia. The screen is yours.
Hello, Dr. Geeta. Thank you for this invitation, or also for the Malaysian Association for the Study of Obesity. So I've been very, I've learned a lot already through these webinars from the other presenters. So I hope that I can bring a different perspective, particularly after the presentation of Dr. Ginsky, with all the different approaches and policy implications for the prevention of obesity. So I'm going to share my screen with you. I hope you can see it. Is it in presentation mode? Okay, thank you. So what I'm going to bring is a lens of equity when we design and implement digital health solutions for the prevention and management of obesity. So the objectives of this presentation is first to give you a list of the digital tools that are available for prevention and management of obesity. So as today, so the list is increasing, I think, day by day. And then what does the evidence say from a researcher's perspective? What is the impact and what are the conditions for these tools to have some effect in terms of weight management, of increasing physical exercise, improving nutrition, and so on. And then, does it work for everyone, even those with proven impact? Does this impact is limited to a certain groups in the population, or it works for all? And then, how to ensure that the impact of these digital technologies are secure and equitable and do not exacerbate existing inequalities in health. So first of all, I'm just going to give you this list of the digital health tools. So when we talk about digital health tools, and particularly in the context of managing and preventing obesity, the mHealth are the ones that tend to be more salient. So they are used for calorie tracking, for changing habits related to lifestyle, nutrition, and exercise. But we also have the wearable devices and smart trackers to track activity and to give real-time health data. There's also the telehealth and virtual weight management programs where people can have contact with a human coach and they can discuss the options for weight management. There's also the artificial intelligence and chatbots that provide personalized diet plans and also behavioral support from an agent, from a chatbot, not necessarily a human, well, not a human individual, but will rely on big data, health data, and also personalized data to provide this targeted advice. And then we have the virtual reality and augmented reality for behavioral change, that this is related also with proven interventions of behavioral therapy and gamified exercises where, for example, the person can use virtual reality equipment to see, to imagine how the body will look like after a certain diet, for example. So that will work as a motivation to achieve the target. And then there's also the online support communities and interventions that relies on peer motivation and social support for strangers, that not necessarily people that have some contact in real life. And there's also smart kitchen appliances and meal preparation technology that has to do with the smart scales, with smart blenders that count the calories in the food. So it has to do with the Internet of Things that also provide some data that can be used to target personalized plans for weight loss. And then there's the digital therapeutics and digital programs that they are like platforms for clinical proven weight management that combine AI with behavioral therapies and also with real-time tracking for biodata. So with all these different options, what are the considerations that we need to have? So would they work? Which ones will be the most appropriate and for which populations? So the evidence for impact is clear. So, for example, reviews of health apps for weight loss and obesity management found that apps that incorporate behavioral modification techniques such as self-monitoring and goal setting were more effective. So it's not the app, is not the technology itself. The technology is just a resource. So the technology needs to be accompanied by an intervention that is adequate for a certain group. Other evidence for impact has to do with gamification and real-time feedback that really works. So several studies, including randomized control trials, show that there's a decrease in the BMI index when gamification is used. And gamification in these digital health interventions is particularly effective when we are talking about children and adolescents. And even that studies that show long-term impact are very rare. There are some studies that show that the gamification that promotes engagement for around 12 weeks. Other studies that use digital health platforms also show evidence of weight loss. And digital health platforms are the AI tools that may combine, for example, chatbots with participants that are using other therapies, just as the GLP-1 receptor agonist. And so when we compare engaged in the platforms with non-engaged, the engaged groups are the ones where the mean weight loss and faster achievement of clinical significant thresholds worked. There's also some studies that provide evidence for health behavior change with the mobile health. And it can lead to weight reduction and maintenance as a standalone treatment. So these are more based also with behavioral change and not only the therapy. It's when combined with the technology and the behavioral change therapy. Sorry, that's what I wanted to say. And finally, so mobile health hubs they are clinical proven that they will improve obesity prevention by promoting dietary changes, increased physical activity, and better sleep. So it has to do with the mechanism whereby the mobile health has impact on obesity management. So what can we take from this study? So this is just some examples, but there are numerous studies that show the impact, or not all show impact, of these technologies, for digital technologies for obesity prevention and management. First, it shows that there's promise. So there's many examples of technologies that effectively work. But the effectiveness varies across different technologies. There's also not one size fits all. There are some technologies that are more appropriate for certain people. So the characteristics of users and technologies interact. For example, gamification works better for children and adolescents. The smartphone applications also require user interaction, are more effective than passive wearable trackers. I think we discussed that already, that the engagement, it's very important, the human touch and the emotional involvement. So the technology per se, a tracker, won't have any effect if it's not associated with a plan for continuous engagement. For example, using personalized coaching and peer support. So the key elements for successful digital interventions, irrespective of the technology that is used, is self-monitoring, goal setting, personalized feedback, real-time feedback, and participant engagement. These are the elements that need to be there. So while these digital interventions show some potential, we also need more research to understand the long-term effectiveness and the optimal implementation strategies. So we need more long-term studies, and we need more standards for quality of the interventions. So what are the equity challenges of these digital health tools? First is the digital access. So when we talk about access, it's not limited to people owning or having access to the technology. So because in some cases, people don't own, but they share the equipment with their peers, for example, for the adolescents, or in a household among a couple and children. So the support and the dependency is also important, particularly for older groups who are not as literate and skilled in terms of technology, that may have, for example, a son that can help them and navigate these challenges. So the meaningful use is also important. It's not just because people have access that the technology is going to be effective. So people need to use it in a way that will benefit them. And also there may be some barriers related not with access, but how people perceived the access, how easy they think is to use these technologies. And if they are relevant for their life, if they have time to use the technology, if they trust the technology and they trust, for example, the information that they are sharing, they are providing the technology, if they are interested in technology or not. There are people who are technology averse. And if, for example, the technology takes into account the specificities, for example, people living with disabilities, if the technology is adapted for them. And then there's the question of the digital literacy. So this is related with the skills and abilities for necessary for digital access. So people need to know how to use the technology. And sometimes there are considerations that the designers are not taking into account. For example, with language skills. So when we design a tool, we should design considering different languages. So people have the same level of accessibility. And also the question of self-efficacy that is a individual characteristic, but has to do with the trust that people have on themselves, that they are able to use the technology, and the readiness for people to also use the technology. But if you go up from these more individual characteristics to more social characteristics, there's also technology norms. Communities, they may have preference for specific tools, and you can see that, for example, in social media, whether people prefer to use Facebook or if they prefer TikTok or other social media platforms. And this is also related with age and, of course, country and the level of education and so on. So this needs to be taken into account. There's also gender norms on technology use. Women who may be inhibited from using technology, for example, to communicate with other people, with strangers. And so it's important also for these technologies to be co-developed with the community, because in that way, it's possible to design for a certain community, taking into account these norms that people can recognize, and using also community partners. And there's also some equity challenges that are embedded in the technology itself that has to do with the design. For example, the developers that design for a certain group, they may have some implicit bias or some preconceptions about the group. Or there may be some, and this is also evidence that there's racial and gender bias in health algorithms that are mainly derived from biased data sets. So if there's differences in terms of the access to these technologies, the data sets that result from the users' engagement, they are not going to be balanced. So the algorithms are trained in this biased data. It means that they may work in terms of the benefits of the technology, can work better for certain groups for which they have more data, is more represented, than for other groups that are underrepresented. And finally, there's the challenge related with the infrastructure and policies. So the access and cost of equipment, the broadband internet, existing policies for technology adoption, for innovation, for data protection, for design standards, and so on. So these are just different elements of the equity, but how can we bring them all together in a coherent framework? So very recently, social scientists, they start talking about these digital determinants of health. As you know, there's the social determinants of health, the commercial, and now the digitals is a different level of determinants. That is, they are connected with all the others, but they look at all these different aspects that were introduced, that can introduce inequities with the adoption of technology. And most of them are those that I already talked about, but I want to show you just a framework for digital health equity. And this can be applied to all types of digital tools. It's not exclusive for obesity. But the idea is that if you look at the digital environment, is just one part of the context that will influence health outcomes. So we can think of different levels from individual, interpersonal, the community, and the societal. There are, for example, the individual factors. They have been placed a lot of emphasis, but this is normal. As human beings, we have this fundamental attribution error that we want to, when we try to explain behavior, we tend to focus on the behavior of individuals. So we tend to focus obesity in the habits of the individual, of their willingness, and so on. So, but the environment, the built environment, the digital environment, the social cultural environment, and even the health system, it also influences in a high degree the outcomes, the health outcomes of the individual. So we need to bring all of them into account. And so this is a study that I think is one of the few studies that look at the different interventions for obesity prevention and management from a health equity lens. So this is a systematic literature review of that was published recently last year. Look at different studies, mainly for adolescent obesity prevention, and applying this lens of the different factors for health equity, from digital literacy, self-efficacy, access, data standards, and so on. So the red means that that particular issue was not addressed. And the green means that the issue was addressed. For example, we have a study among this literature review. There's a study in Malaysia that was based on an intervention called ObesGo. So there's a website where I think in adolescents and parents could check for information about healthy lifestyle, diet, and ways to overcome obesity. And this was mainly with adolescents who are obese in Malaysia. And there was a combination of just information with the website, with self-monitoring and interactive sessions and so on. So this is a study that includes one of the components of the health equity that has to do with the understanding the community tech norms, mainly comparing Malays with no-Malays. So one of the reasons I'm showing this literature review is just to show that there are some studies that were done also in Malaysia with a health equity lens, and I'm going to show you one in a minute also. So one of the best examples of the equity lens, using equity lens in an intervention for obesity, is just one study that used only to address two equity issues that are related with the technology access and with the community infrastructure. That is a study, I think, in the US that use iPads, that provide iPads and internet access to high school students, and where combine televisits with teleconsultation and primary care provider visits. So, but it's still not enough. It's still nothing. Just thinking that we need to provide the technology and the internet access, because if you look at all these different levels of inequity and how they interact with each other, we can see that these interventions are not designed for equity. So I'm finishing very soon. So this is an example from Malaysia. Probably most of you have heard of the Better Health Program that aimed to co-create a community-based digital intervention for low-income populations for before 40, and to enable community stakeholders to address obesogenic environments. So this idea that obesity prevention is not only focused on individuals, but there are environments that are obesogenic, and to improve people's knowledge, attitudes, and practices related to NCD, non-communicable disease risk. So it was focused not only on individuals, but also on community health volunteers based on the COSPAN program. And the different aspects of the health equity, I think, are worth noting. That was they use the digital health needs assessment to inform modification of digital health tools to support the project aims. So they identify what were the readiness, or was the trust, there was the interest, the relevance for the technology, and this was used to modify these digital health tools. There was also a co-creation with the community, with the people in the community, and also with the community health volunteers. And they look at the community preferences for different options for interventions, to identify the interventions that will be most locally relevant, feasible, and needed. And there's also the sustained engagement that was already identified of one key factors for success of digital health interventions, in this case with the community health volunteers. So it was also proven that the sustained engagement with professionals will lead to better long-term health outcomes. So in terms of the recommendations, there are many, but I just identify 4 recommendations if you want to design and implement and evaluate digital health tools to prevent and manage obesity. So the first is we need to have a framework for digital health equity, not only in the implementation and the design, but when we evaluate the impact of these interventions, it is not only to see if the BMI is reduced. We need to identify in terms of reducing also health inequities, and to see if that intervention worked for everyone. And then the second recommendation has to do with broadening policy considerations. So consider interventions not only focused on individuals, but upstreams, to consider also the societal level, for example, digital infrastructure, the policies related with standards for design, for data protection, and see which ones may be more effective in certain populations. And also is important to train healthcare providers on digital literacy and equity. And there's also the question of the implementation per se. So even if you have a digital health intervention that has proven results, that it works for certain populations, it doesn't exacerbate health inequities, it doesn't mean that it works, for example, in different regions and in different countries. So we need to understand what are the contextual factors that lead to the success of the intervention. So we need to do some implementation science studies to understand the contextual barriers and strategies that can be used to overcome those barriers. So, and for that, community engagement is essential. Also for trust building. When we implement an intervention in a community, we need to have the buy-in since the beginning and the involvement of the community. And then we need to consider the broader social and digital determinants of health. And this is for stakeholders, not only for policy makers, for innovators, for developers, but we need to understand what are these social determinants of health, and how the digital tools interact with them to create these health disparities. So we need to understand, and we need to have good examples of implementation and design, that, for example, to have fair and biased algorithm development, or, for example, when we design to have these multilingual options, to have versions that work with the low tech, that are free or low cost. So when we design, we take into account also the challenges of marginalized populations. And yes, so that's what the main points that I wanted to discuss today related to the equity. And I hope that you can link it to the knowledge that we have about using digital tools for obesity prevention. Thank you.
Thank you, Dr. Claudia. In my personal opinion, I do think your talk complement Dr. Ginsky's talk just now, because you go more in detail about the health equity. The equity part is very important, given in a multi-racial, multi-population subgroup of population in Malaysia, for example. So we need to understand the details of cultural background, socioeconomic background, and so on, before we do any of these digital solutions. So that's really very much complementing each other's talk, which is really very good. I have one question. Audience, if you have any question, please also type in the chat box while you're doing that. Maybe Dr. Claudia can, in your experience, have you come across any study or any of these digital solutions that have tracked and evaluated whether these digital solutions that take consideration of these different equity, the different details of population, are actually reducing obesity gaps between the population groups? Do you have any idea on that?
Yeah, I didn't find any. I wanted to bring a good example for obesity, using digital health for obesity, but only one that I found that was very well designed. And it was just a protocol, was not the results of the study. It was from the Better Health Program in Malaysia. The other systematic literature review with all the other studies, the maximum that they would tackle was 2 types of inequities. So they were not even designed for equity. So we don't think that the evaluation and impact was also not taking into account equity. So we need more of these studies, more studies at all.
There's definitely a gap in this area that we need to address to ensure the intervention, reach the population that is intended to. So we are not leaving out any of these population group. So that's really good. I don't know whether there's any question from the audience. Yeah. There's no question from it. So I suppose we don't have the best model yet, but these are the important aspects that we have to learn from each other, I suppose, because we are now moving forward, and we really need in the environment where there is a lot of limitation, for example, resources, fund, staff. So we have to rely on digital solutions. So I suppose when we want to do this, and we have to really take into account of the equity part as well. Maybe you have anything to say on that?
Yes, absolutely. And I think innovation, is so rapid at the moment. The pace is so rapid that we need to develop policies that address these inequities, and we need to have these standard operation procedures for design that also tackle these inequities, because I think the innovators and the developers, the mindset at the moment is that let's have innovation, and then we see how can we correct. But on the way there, we are not doing a favor for the people who are the ones who need this technology the most. And when we think about developing technology, we need to think of developing offline solutions for those who don't have the same access and they don't benefit as much. So, we tend to think that access and literacy is everything, but it's not. There are people who have access and who prefer not to use technology. And maybe we are going through a future where people who have more resources, more education, more wealth, they reject the technology. They prefer to have the human touch and the interaction with one-on-one with a medical doctor, whether people who don't have the same resources and education will be resigned to have these mobile health and technology interventions that work at large scale, but with the benefits are not very well understood and not as high as if they have the human touch in the interaction. So we need to think that, and not think that technology is never a solution. It's always a tool. We cannot say it's not good and bad. There's nothing judgmental inherent in technology. It's the way that is used. So there's this hype of a new technology, but the way that is implemented and designed is crucial for the impact.
Yeah, I agree. I totally agree with you, Dr. Claudia. And for that to happen, we need more data, I suppose. Yeah, so that's definitely a gap. I hope this gap will be addressed for some of the academicians, local academicians or international academicians, so that we have more data in hand to convince larger scale digital solutions in many countries, not only in Malaysia, definitely in many countries as well, because obesity is not a Malaysian problem, but also a problem elsewhere. So thank you so much, Dr. Claudia, for your time and for your talk. It's really very good. We are very happy to have you here today, and thank you so much for your talk again. Yeah. Okay, so with that, ladies and gentlemen, thank you so much for your time being here up to now for almost 4:45. So thank you so much for being here. I just want to highlight to you, we have another 2 more webinars. So we have webinar 2 on the 5th of March 2025 between 2 to 4. We have 3 speakers in that webinar. Encik Nazli from Nutrition Division KKM. We have Professor Tim Gill from University of Sydney, and we also have Professor Nur Hasma from UPM, who will be talking about policy options in combating obesity. There will be some updates to this. So please join us on 5th of March. And we have another webinar, the last webinar for this week. This is about Ramadan and weight management. So we have 3 esteemed speakers as well. Prof. Nisa, Barakatul Nisa, President of MDA, and Dr. Sindo Nair from UPM, also Prof. Dr. Hazizi, Associate Professor Dr. Hazizi, Vice President of MASO, who will be talking about physical activity and how to do it during Ramadan for you to help you with your weight management journey. All right, so please join us in these 2 webinars. We also have, next slide, this one is very very interesting activity that we want to do. Part of this Obesity Week Malaysia is this 7-day Walk the Fast Ramadan Challenge. We're doing this because it's a month of Ramadan, so we want to be tailored to reach Ramadan challenge. This is a 7-day Walk the Fast, so please walk as much as you can. Of course, the highest people with higher steps in walking will win. So please walk as much as you can. The more, the better. And this is between 10 to 16 of March 2025. You need to stay active. This Ramadan stand a chance to win exciting prizes. We have cash prizes as well as one-to-one diet program prizes for you to win. And we have 2 categories here, Muslim and non-Muslim. Of course, we cannot be similar in this case because Muslim are fasting, obviously. So there's 2 categories. So the highest people with highest miles or highest number of steps will be contacted, and they will win. But you have to read the rules. We have several apps that we can use. Please read the rules by clicking this link here and register yourself and join the activity. Next one. Is there anything else, Dr. Razi? Okay, so that's all. Thank you for joining. Those who have joined, this is a QR code for you to fill up some post webinar questions. Fill that up and get your certificate from us. So there's a code for you to submit. You have to submit this code 2025-0303 and you'll get your certificate sent to your email. So thank you so much for your time once again today. We will keep this for a while, so you can snapshot this QR code, or you can even do it right away right now and get your certificate. Thank you, and I hope to see all of you again on the 5th of March.